The definition for secondary PPH is when there is excessive uterine bleeding after delivery. It can be vaginal delivery or cesarean section from 24 hours to 6 weeks after the delivery is done. So basically, this is the definition of secondary postpartum hemorrhage. Now, when I'm talking about a secondary postpartum hemorrhage, what might be the causes that the bleeding is happening, the pathophysiological causes? So the pathophysiology behind that, there are a few causes that I need to know. First of all, what stops bleeding after delivery? The first most important reason is going to be your myometrial contraction or involution. So of course, you know that we call the myometrium or the uterine smooth muscles as living ligature. Living ligature is basically, it is literally something that ligates all the vessels, all the spiral arterioles that are supplying your uterus after delivery. And it is not just contraction. In fact, one thing that you have to remember is whenever you're putting a round for a postnatal patient, you shouldn't really be writing well contracted uterus. A better term is well retracted uterus. Contractions are what happen during labor or antenatally. Contraction and retraction, there is a difference. In contraction, that organ is going to become smaller, but then it will again regain its original state. Whereas in retraction, there is contraction, but the original size is not regained. So every subsequent minute, the size is going to keep getting smaller and smaller, and it is not going to regain its original size, which is why after delivery, what happens is retraction. The uterus now has to become after 6 weeks or until 6 weeks, 6 to 12 weeks, basically, it has to become a pelvic organ again. Hence, the size has to reduce, and hence, a better term that you should be using is uterus is well retracted rather than contracted. So, myometrium involution, which leads to retraction, is one of the major reasons why your uterine bleeding stops. So, any pathological problem in this involution is going to lead to excessive bleeding. Apart from that, if there is any injury to the uterus, then it is going to bleed. Of course, it is going to bleed more so in the earlier 24 hours, but it is one of the reasons why excessive bleeding can happen. And apart from that, if your endometrium has not shed, or a better term to endometrium is your decidua. So these are all the reasons how your uterus can bleed excessively and your body is going to bleed excessively. Now, whenever this is deranged, so basically if there is subinvolution is poor involution of the myometrium, then you're going to be having open sinuses. Your vessels are going to stay open. They are not going to be they are not going to be constricted. They are not going to be constricted by the myometrium. So open sinuses and also placental bed. Placental bed is basically the exact area where the placenta was implanted or the placenta was situated, because those areas are going to have lots of vessels in them. Secondly, again, as I mentioned, because of subinvolution, if there is retention of placental tissue or membranes, and once these membranes are retained, they are going to become a rich nidus or a rich focus for infection. So infection is going to follow, and infection, if uncontrolled, it is going to become sepsis. Sepsis that is occurring in the first 6 weeks of pregnancy is also called as puerperal sepsis. This sepsis or infection is going to increase the inflammation of the uterus and the endometrial or decidual, whatever you may call it, decidual lining, because of course, infection is going to lead to acute inflammation. And one of the forms of inflammation, or one of the classical features of inflammation, happens to be increased vascularity of that area. Rubor, color, dollar, all those things that you read in inflammation. And if the vascularity is open, we have already read because of that subinvolution, the bed sinuses are lying open, the bleeding is going to be excessive. So now a lot of people, when they talk about secondary PPH, they say that the most common cause of secondary PPH, they say, is infection. Remember, it is not really infection. Infection is one of the reasons why all this might be occurring, because whenever there is infection, the subinvolution is going to worsen. So infection might be a precipitating factor, but the cause of bleeding is not by itself infection, because why should infection lead to bleeding? I mean, just imagine you have gotten a URT, that is upper respiratory tract infection. That area doesn't bleed. So what is the cause of bleeding? The cause of bleeding is the subinvolution that may occur because of infection or because of the retained products that have stayed inside. Retained products are not necessarily because of subinvolution. They can be because of subinvolution, because of course, whenever your uterus contracts, so if this is your uterus, and if this inside was your placenta, so when your uterus contracts, the placenta gets separated. So when your uterus becomes smaller, your placenta has a very lesser area to get implanted. So it gets separated from that site jahan pe it had gotten implanted. So involution is going to help in your placental expulsion. So if there is subinvolution, of course the placenta is going to be retained. But even without your subinvolution, if there was something like placenta accreta, wherein the placenta had gotten adhered to the incision. So if there was something like it was an anterior placenta, if your placenta was anteriorly located, and if there was also your previous caesarean scar that was there on it, on the uterus, your previous curved incision that was there on it, and the placenta is now adhered to it. So major bits have been expelled, but a few bits stayed inside, and this especially can occur after vaginal delivery in a TOLAC patient, that is trial of labor after cesarean has been given, or VBAC if you call it that way. It may happen more commonly in those patients wherein the placenta has gotten adhered to that incision, and you thought that the majority of the placenta has been delivered, so there might nothing be that there is nothing that may be remaining inside. So that is one of the reasons why that bleeding may occur, because of the small retained bits of the placenta at this incisional site, previous scarred incisional site. So this is one of the most important causes that you need to know of secondary PPH, and this is the cascade that takes place. But again, infection is one of the initiating factors and not the sole reason why a person or a patient should have PPH. The major reasons are going to be because of the retention of placental tissue, which in fact we also call as RPOC, retained products of conception. So the most important and the most common cause is retained products. Then you also have subinvolution, which is the second most common, and then you have infection, which leads to all these things. This is the most common reason or the most important pathophysiological event that leads to secondary PPH. There are a few much rarer causes that I have that might also lead to secondary PPH. What are they? So a few other causes are going to include a few rare causes. What are those rare causes? So when I talk about rare causes, imagine that you are delivering a patient or delivering a baby, or you were doing a cesarean section and there was some injury that was sustained to the uterine artery. Now imagine, I'll just show you a picture over here. So in that injury, your uterine incision got extended slightly, and that uterine incision extended up to the uterine artery. So yeah, this picture. Now look at this image over here. Now look at this image over here. Imagine that there was your uterine artery and all its branches, and while taking an incision or while delivering the uterus, the wall of this, you see, this wall has been damaged over here. So this is a damaged point over here in the uterine artery. So this was your uterine artery. Basically, this is your internal iliac. It goes into two branches. The one that goes up is your uterine artery, and the one that goes down is your descending cervical artery. So your ascending branch is your uterine and all these other branches that it gives inside. So there was a damage to the wall of your endometrium. Of course, there are three layers that are present. The outermost is your adventitia, the middle is your media, and the innermost is your intima. So your intima and your media are damaged and only the adventitia was intact. Now, because the adventitia, that outermost layer, the tough outer layer of that uterine artery, that vessel was intact, hence you didn't immediately see the bleeding during your surgery. But after that, because the tunica media, the muscular layer is gone, there was a small collection, a hematoma that was occurring in the wall of your vessel. So you see this kind of a hematoma that was occurring inside. This hematoma took some time because the adventitious layer was present. It took some time for the blood to trickle out from those layers and start forming a hematoma. And in that 1 or 2 days were gone. But after that, once the hematoma became so huge that it finally just ruptured, as you see in the C image, and that rupture is now coming out as bleeding from the uterus, and this bleeding can of course be torrential because the hematoma has ruptured after a long time of its formation. So there's a lot of blood that is accumulated inside that is going to come out as a trickle, and the trickle is not going to stop. This is called as pseudoaneurysm of uterine artery. The pseudoaneurysm is basically because of an injury that was sustained during delivery, during surgery, or whatever, but it was not an immediate effect because the injury was not that prolific that it sheared off the adventitious layer as well. Probably there was too much of pulling of the uterus because of the baby delivery being difficult or something, or you used a forceps during cesarean section to deliver. So the adventitious layer was intact, but the inner layers got torn off. This is called as a pseudoaneurysm of the uterine artery, one of the uncommon but definite causes of secondary postpartum PPH. Apart from that, a few more things can happen. So one of the causes that we discussed over here was pseudo aneurysm of uterine artery. Now another cause can be an arteriovenous malformation. What's an arteriovenous malformation? Arteriovenous malformation is basically, by the way, arteriovenous malformation now has been taken as a separate entity, and what we use now is EVM. EVM is extra matrix vascular malformations. So basically, what EVMs are, they are basically connections between your artery and veins, and those connections are the one that start bleeding. AVM is a term now that is used only and only for congenital connections between your arteries and veins. So it is no longer a term that you use for an acquired lesion. Enhanced myometrial vascularity. I'm sorry, that is my mistake. I'm sorry about it. But yeah, EVM is a term that we now use it only and only for acquired lesions of connections between your arteries and veins. How do you diagnose it? Of course, AVM and EVM, you cannot know about it, whether it is congenital or not. But to diagnose it, the diagnostic criteria is fairly similar. You have to see the peak systolic velocity you have to see the peak systolic velocity of your vessel, and if your peak systolic velocity is more than 60, then it is definitely a vascular lesion. If it is less than 30, then it is ruled out, whereas between 30 and 60, it's a gray zone where you have to keep on monitoring the progress at a regular interval Doppler that is done, so as to know whether it is progressing towards EVM or it is regressing and the vascular region is regressing. Now, why should this happen? This happens mainly if there is any small bit of placental tissue that has been retained inside and the rest of the tissue has been removed. So what happens is, if imagine there was this big a placental mass, if there was this big a placental mass and the entire thing was removed, but there was one small place that got retained inside. Now the majority of the mass has been removed and only this small bit, now I'm showing an enhanced or a magnified image of that. Gradually, because this mass has been removed, the vessels that were supplying this placental mass or the placental bed have been detached. But because they come to know that there is one small bit that is remaining, all of these vessels come towards here. So they start coming towards this bit, and the veins and the arteries in this small area start getting anastomosed. So there is anastomosis of these veins and arteries, and these are very thin walled structures, very much like a capillary, and these can bleed immediately. If the blood flow velocity increases inside them, they are going to start bleeding out. Now they bleed because the capillary wall is not capable enough of handling a high velocity flow inside it. So these vessels or these connections are typically described as high velocity, low resistance vessels. Low resistance because, as I said, they are very much like a capillary and they lack a proper tunica media. And because the tunica media is negligible to absent, they will not have a lot of resistance inside them the way spiral arterioles did. Hence, these are not true vessels. These are connections that are formed between the arteries and veins. Now, these vessels, when they start bleeding, the bleeding is going to be again a trickle, or if there is a large vascular mass, then it is going to be excessive, but it is going to be continuous. But remember that this or these connections take some time to occur. It may even take 2 to 3 weeks, and hence the bleeding that starts after 1 or 2 weeks can be attributed to AVM, or what's the new word for it? That is EMV. So this is yet another important cause of your bleeding through your uterus as a part of secondary PPH.